Good afternoon, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Mission NEEV webinar, uh, New PPH Guideline, Changing the Way the World Saves Mothers. So it's my privilege to introduce the expert and program director of this webinar, Dr. Shada Jain ma'am. Ma'am is fondly known as Teacher of Teachers and Director of Life Care Center in Life Care IVF. I welcome you, ma'am. And it's my honor to introduce Dr. Archana Verma, ma'am. Ma'am is past Vice President of Foxy and Founder President of West UP ISOPAP chapter. I welcome you, ma'am, and I hand over the session.
Thank you. It's first of all, welcome to all dear friends and all respected teachers and Sharda Jan Madam and Speaker Dr. Pratik Tambe. It's really my proud privilege to welcome all and to present here at a time today when we all are really working for saving mothers, which is a must, and because India has to do a lot in this mission and work, because saving mothers is the priority, national priority also, and reproductive health and their antenatal care and the postnatal care is much more has importance, and the prevention part still holds a lot. And as madam says, it is more than 80% if we do the understand the things and do the prevention properly. So this meaningful series of mission NEEV, we are doing webinars and other programs also. So Mission NEEV is not just a mission, Dr. Pratik ji. It's a commitment towards safeguarding women's health with dedication and standard protocol. And for that, Dr. Shardajan Madam has made up that special guidelines and with the WHO and FIGO guidelines, and she has made a PPT and has presented this as an academic gift to each and all of us. And just with a mission that one Rashtra, one protocol, one PPT, just to create that small steps, and it will have great impact in creating uniformity and not avoiding all unnecessary intervention by unknowingly and not under protocols. So this initiative has been, as you already said, that possible because of the visionary leadership of Dr. Sharda Jan Madam, who transformed this idea to reality. And this preparation of PPH is aligned because with the FIGO and WHO guidelines. And this SDG goal we all know, and Dr. Pratik will be talking about these guidelines in a very subtle way. So I invite Dr. Pratik Tambe, today's star speaker. And we all know there's only I think no one in this gynecologist world, nationally or internationally, who doesn't know Pratik Tambe. This is not, I think that I had this CV, so I've just shared this only. He is at very recently, he won the secretary of election for the ICOG, and it was that they are at that time it was this slide was made, and he is really a very academic person, and so much to read and so much to say. But only one thing, he is a real worker, real hard worker, and a real friend to all. And I think on academic front, he has created wonders. Daily, almost every week, he publishes a 1 week, and then he shows, just see, I've just published this book. So welcome, Dr. Pratik. Welcome to you. Now we want to listen to you only. And
Thank
welcome
you.
all our national experts also, Dr. Niharika Malhotra, Dr. Sneha Bohar, and Dr. Taru Chaya, Dr. Sangeeta Gupta. And before I invite Dr. Pratik Tambe, I want to invite Dr. Shardajan Madam to give her words of wisdom and blessings to us, all of us. Madam, Sharda ma'am. मैडम आपकी आवाज नहीं आ रही. Pratik, can you listen to her?
No, I think Madam's audio is low.
It's far away from the microphone.
Yeah,
हाँ, आवाज नहीं आ रही.
Madam
Okay,
is
okay.
without computer audio.
Okay. Dr. Pratik, you start, and Madam will join again
Sure, no worries.
after
Do
some
you
time.
want the chairpersons to
Her
speak?
blessings are with us. Huh.
chairperson से कुछ
They will
कहलवाना?
speak after you.
Okay,
हाँ.
ठीक, fine, good.
Hmm.
So let me begin by thanking Dr. Sharda Jain Madam, Dr. Archana Verma, and all the respected dignitaries who are here today. I'm going to be talking a little bit about prevention of PPH and currently what are the management principles for this particular purpose. Now, PPH is something which is well known to all of us. I'm not going to give you something very new or out of the box. Most of the concepts that I'm going to discuss may be known to you, so it will be just a revision. What I'd like to think humbly and respectfully is that maybe we need to reorient ourselves, we need to refocus our efforts, and try and ensure, as Dr. Archana Verma said, that none of the pregnant ladies in India should lose their lives because of a preventable cause, which is postpartum hemorrhage. That would be a tragedy in today's world, in the 21st century. In the 1960s, 70s, we've all seen those Bollywood movies where the doctor comes out of the labor room and says, "Bachche ko humne bacha liya, maa ko nahi bacha sakte." And women were dying in childbirth at that point of time. That was 50, 60 years ago. Hopefully, we don't have those kind of tragedies in today's world. So without further ado, let me begin my presentation. Whoever saves one life saves the entire world, says the Australian author Thomas Keneally. And I'm sure all of us appreciate that the woman is the center of the family unit in India and to most of the developing world. The entire society revolves around the woman's contribution and the woman's role, not only in her family, but also throughout the community. And therefore, saving her life should be of paramount importance to us as OBGYNs who care for these women when they are pregnant. I've structured this presentation in the following format. We look a little bit about the epidemiology. We discuss the different projects, namely the FIGO Ampli PPHI project, which I was fortunate enough to be part of. We discuss the current scientific and standardized approach, which has been laid down by WHO, FIGO, and many international bodies. And then we can talk a little bit about the practical implementation, how each of us can make a difference and save women's lives in today's world. WHO came up with this position statement sometime a couple of years back in February of 2023. And the startling statistic was that even in 2023, every 2 minutes, a woman was dying somewhere of pregnancy or childbirth related complications, which is unacceptable in today's world, where we take a lot of primary health care and basic health care for granted in the developed world. And I like to think of India no longer as a developing country. We are number 3 in the world in terms of gross domestic product. We are one of the largest economies anywhere in the world. So at least in India, this is something which is not something which we would like to have happen to us. If you look at the statistics, postpartum hemorrhage is the most common cause of maternal mortality even today in 2026. Like I said, in the 60s and 70s, it was something which was much more common. The figures then were in hundreds. But today you will find that the figures are around 145 per 100,000 live births. This equates to about 70,000 deaths per year. 14 million women are still experiencing postpartum hemorrhage every year. And the SDG goals were to target 70 per 100,000 by 2030. We have already exceeded those goals in India, but there are many parts of the world which are still lagging behind. And therefore, in October 2023, WHO issued a global plan to tackle postpartum hemorrhage. And this is displayed on the WHO website. This is directly taken from there. And they have multiple position papers which came in after this. And the most prominent of these was the WHO roadmap. And this roadmap looked at many different aspects, not only the medical aspects, but also the challenges in implementation, detection, and research to deliver innovations in this field, which was very much the need of the hour. And this is the original roadmap document, which is published on the WHO website. You can go back and have a look in case you're interested in looking it up. Freely available on the internet, not behind a paywall. If you can't find it, write to me. I'll be happy to share a copy with you by email. There are multiple different contributors and partners who have come up with WHO, with FIGO, and these include the USAID, the BMG Foundation, MSD for Mothers, and JAPIGO, to name a few, all of which are operational today in India and many countries in Africa as well. The four main arms which WHO said were important as far as PPH prevention were concerned were research, standard setting, advocacy, and implementation. Now, we as doctors are commonly responsible or tasked with the implementation part. But I would argue that as clinicians, as opinion makers, we have an equally important role to play in the advocacy standards and the research parts or the arms as well. And one such effort in that direction was this Ampli PPHI project, which was launched by WHO and Tobago in association with FIGO. And I had the good fortune to be part of one of their programs which happened at AICOG in Hyderabad in January of 2024. Specifically, there were five priority areas which were recommended to be updated. Number one was implementation of carbetocin for PPH prevention. Number two was tranexamic acid being given additionally to oxytocin at the time of cesarean section to prevent atonic PPH. Third was to have transfusion of co-packed RBCs and fresh frozen plasma in the presence of continuing blood loss. Number four was intraoperative cell salvage, which we used to do once upon a time way back in the 80s and 90s when we were medical college students. And later on, it fell by the wayside because it was seen to be as not evidence-based. And lastly, of course, IV iron to be given for postpartum anemia to these women. So this is a picture of that Ampli workshop which we had at AICOG in Hyderabad, and we had Professor Ann Kiara, who was then the PIGO president, Dr. Nandita Palshetkar, you can see Ajay Bharadwaj, who was one of the key people in that entire project from the Ampli PPHI point of view, and many other dignitaries as well. The current PPH bundle management approach is well known to all of us, and this is the document which laid down those recommendations published in December 2023. Again, this is on the WHO website, and this most importantly recommended that there has to be a standardized way of routinely, objectively measuring postpartum blood loss. And that is where those drapes come in, and you've been familiar with all of these concepts. Most of them have now been implemented in routine practice, but still in some of the smaller towns, smaller, how can I put it, taluka places and villages, this has not yet been implemented, and that is what will make the difference to understanding and early diagnosis of PPH in these women who deliver in these inaccessible and remote areas. The second recommendation is administration of oxytocic agent and tranexamic acid. And which is the oxytocic agent which is recommended by WHO? We'll come to in just one of the slides. And these care bundles have been discussed in many different meetings at various different fora, many panel discussions. So I'm going to skip past this and go straight to the technical guidance. So this is the WHO technical consultation, which was published in May of 2019. And there were multiple collaborating authors from all over the world who contributed to this publication. And they looked at some of the key evidence to arrive at a consensus as to what are the recommended uterotonics. WHO recommends that an effective uterotonic should be used for prevention of PPH during the third stage of labor. And the recommendations are either oxytocin, carbetocin, or misoprostol. These three are the most commonly used in clinical practice. In India, we don't have the fixed dose combination of oxytocin and orometrin, which is available. In certain parts of the world, that is still available. Number two, they said that carbetocin is recommended for prevention of PPH for all births, especially where the cost is comparable to other uterotonics. And if you find that there isn't good quality oxytocin that is available, namely you don't have facilities for refrigeration, good cold chain maintenance, then it is recommended that you should refer to carbetocin because it is heat stable, and you will find that it can easily be maintained at room temperature. Even in the hot Indian summers, the temperatures are now well in excess of 45 degrees, even touching 50 degrees in certain parts of the country at the height of summer. Injectable prostaglandins, which we used to use very honestly once upon a time, like carboprost, are not recommended for prevention of PPH. They are second line drugs which are to be used in the established PPH. And here, this is the point that I was saying, that in settings where oxytocin is either unavailable or its quality cannot be guaranteed, then other eutotonics such as carbetocin are recommended. And in smaller towns and primary healthcare centers, misoprostol 400 or 600 micrograms given orally by community health workers is recommended for prevention of PPH, especially before you transfer the patient to a higher center. Foxy did a good clinical practice recommendations, or GCPR, way back in 2022. It's about 4 years old, but still very relevant even today because it gives you at a glance a very good flowchart. And I would strongly recommend that you take this and put this up in your labor rooms everywhere. That was the original intention. And through the good offices of many of our academic partners, this has been disseminated to many OBGYNs throughout the country. Again, this is freely available on the Foxy website. If you can't find it, then write to me. I will be happy to share it with you. PPH often happens in settings where the clinician is not immediately available, or you are away, you are attending to another patient. And therefore, it's important to have good skill drills, and you need to have good flowcharts, management protocols in place, excuse me, for your staff to follow. And this is where flowcharts and protocols like this come to our rescue and help to save precious lives. Let's look at a little bit at the updated evidence on carbetocin as it stands. It's supposed to be an analog, which means chemically the structure is very similar to oxytocin, which we've been using for decades now, and we're all very familiar with it. And to reiterate a little bit about oxytocin, we've always thought it's the gold standard as far as PPH prevention and treatment is concerned. Its half-life is 4 to 10 minutes. Duration of action is about 15 to 20 minutes. Unfortunately, you require a continuous IV infusion for sustained action. And putting in an IV is something which you and I as doctors may always take it for granted, but in the periphery or in small primary health centers where a doctor may not be available 24/7, the paramedical staff may not always be up to speed, they may not always be well trained, and in an emergency, they may fumble, they may not be able to put in the standard 2 wide bore cannulas, which is part and parcel of every single management protocol for PPH that we read about. Again, another issue is that during augmentation of labor, if you've already used oxytocin, then those receptors are desensitized, which means that for prevention or treatment of PPH, when you administer a bolus, it may not work as effectively as you expect it to. We've already come across and experienced a lot of situations where it's kept at room temperature, not refrigerated, and the potency of the drug is lost. That's when you need to give many more doses of oxytocin. And the effect, the eutotonic effect, is not always something which is reliable when it is not stable at room temperature. It's been misused in the farming sector, as all of us are aware, and at one point of time it was banned for private firms, and only one public sector undertaking in Karnataka was allowed to manufacture it. And that, of course, could not keep up with the huge demand for the entire country. So this is the perfect situation for carbetocin to enter, and carbetocin is actually listed in the WHO model list of essential medicines. And this is again freely available on the European Medicines Agency website as well as the WHO website. Carbetocin is a long-acting agent which has a half-life of about 40 minutes. You give it as a single dose of 100 micrograms. It's heat stable, which means even in the hot Indian summers of 40, 45 degrees plus, it retains its potency for many months at a time. Only one-time administration is required. You usually don't need to repeat an administration of carbetocin, unlike oxytocin. Multiple doses are therefore not necessary. IV infusions are not required. You can give it intramuscularly. If in a pinch, you can't get an IV, and it doesn't cause receptor desensitization. Cochrane came up with a meta-analysis in 2018, and this is Professor Gallo's meta-analysis, which is quoted very often in many lectures that you will see on the subject. And I'm quoting it again because it has the highest volume of data regarding PPH. Nearly 200 studies, more than 135,000 women in more than 50 countries. The trial concluded that carbetocin may be more effective than oxytocin for some outcomes without an increase in side effects. And this is the data which has actually been picked up by WHO as well for its guidance. and it quoted this Cochrane meta-analysis published in 2018. I'll speak a little bit about the Champion trial. I'm almost at the end of my presentation. And the Champion trial looked at heat stable carbetocin, which we've been discussing for the past couple of minutes, versus oxytocin, which is the gold standard. It's always been the gold standard. And what they found, of course, many of the sites which were there were abroad, but we had 7 sites which were from India, and you can see them listed out here. They were in different parts of the country, Cuttack, Karnataka, and also in Maharashtra, and the BHU in Varanasi in UP. So here we had almost 30,000 women who were enrolled for the Champion trial, and they concluded that the heat stable carbetocin was non-inferior to oxytocin. It matched the gold standard oxytocin, which we had been using for decades together. And specifically, as I said, 7 of the sites were from India, which makes the Champion trial particularly relevant for Indian obstetric practices. When you compare carbetocin to the other uterotonics, which we are all familiar with, including misoprostol, carboprost, and methylobromotrin, you'll find that the side effect profile is much more favorable, lesser amounts of headache, nausea, and vomiting, and can also be used in women who have mild to moderate hypertension, with caution, of course, and also women who are asthmatics. We also have large volume data from India, and here we have data from a tertiary care hospital in Maharashtra where more than 13,000 women in Pravara were administered carbetocin. And you can see that it scores significantly better than oxytocin in terms of atonic PPH, both primary as well as secondary, the need for additional uterotonics, and the requirement for blood transfusion. The blood loss was significantly lesser with carbetocin. And if you use this prophylactically in women who were high risk as well, again, equally, it was effective in these groups of women as well. When it was administered in women undergoing emergency cesarean section, again, it scored significantly over oxytocin 10 units, which was given in a drip. Lesser needs for blood transfusion, lesser needs for conservative surgical management of PPH, and the need for obstetric hysterectomy was also negligible. Elective cesarean section, again, similar results, which shows that carbetocin has been well studied in different groups of women. We have large volume data from Indian settings as well. And there are multiple international guidelines from all over the world which endorse the utility of carbetocin. As far as cost is concerned, that's something which we will always struggle with when a new drug is introduced into our country. And there are a lot of efforts today where the government of India is being persuaded to try and provide it through indenting through the Ministry of Health and Family Welfare and make it available at a much cheaper cost. I'll speak a little bit about tranexamic acid and then we will close this presentation. Tranexamic acid, we are all familiar with as surgeons. It's a synthetic derivative of lysine. It prevents the breakdown of clots and it helps to prevent bleeding. Cochrane meta-analysis in 2015 on tranexamic acid has shown that blood loss more than 500 ml and more than 1000 ml was less common in women who received tranexamic acid. But the key is that this has to be administered within 3 hours of the onset of bleeding. Otherwise, it becomes ineffective. And therefore, WHO in its guidance, as you saw a little while earlier, recommends that this should be given prophylactically to women at the time of cesarean section. Half to 1 gram is what is recommended. We also had the woman trial, which was published in April of 2010. And this looked at women who gave birth vaginally as well as women who gave birth by cesarean. And they concluded, and they studied nearly 20,000 women over 7 years, that death due to bleeding was significantly less in women who were given tranexamic acid. But the key, as I said a little while earlier, you have to give it within 3 hours after giving birth. There is no benefit when it is given more than 3 hours after the onset of bleeding. I'll conclude, ladies and gentlemen, with a few simple key practice points. PPH in today's world in 2026, in a modern developed country like India, which is one of the biggest economies anywhere in the world, something which is unacceptable. It is easily preventable. Our role as clinicians and doctors goes beyond the actual administration of drugs to prevent PPH. We need to be advocates. We need to champion the cause of these newer methodologies, newer protocols, obstetric skill drills. We need to train our paramedical staff. We need to disseminate the knowledge of all these guidelines to ensure that they are observed and followed in those particular situations where we cannot be physically present, which means we need to empower the paramedical staff, the staff of our primary health centers, and all the people who are frontline workers in treating PPH. Therefore, carbetocin is an excellent alternative to oxytocin, especially in countries like ours, where refrigeration and cold chain maintenance is always questionable. Tranexamic acid is very useful, especially if it is given within 3 hours after birth, and therefore implementation of this WHO roadmap is one of the key things that we as leaders in our profession need to advocate very strongly. Thank you for a patient hearing.
It had been wonderful to hear you, Doctor. Can you hear me?
Yes, ma'am, we can hear you. Thank you so much for coming.
It had been a wonderful presentation, and your presentation has given an overview how this final guidelines in October 5th, 2025 came up, in fact. The presentations, Dr. Pratik, which we had made was exactly after the guidelines had been made, line by line, what the WHO has said. And this is what we want, that these guidelines, which were released by the WHO and the FIGO, should reach out to everybody. But I think it was a pleasure to hear, the whole evolution. And you emphasized tranexamic acid. Now, in fact, in the prevention part, it is not there. It is tranexamic acid, according to the new guidelines. It is to be given only once you have the PPH. It is a part of the PPH bundle. And we are also very happy. In fact, in spite of that, the WHO guidelines have come that, it has to be only used when the PPH is there. People like me still use it prophylactically in cesarean section for many years. And I find, it's absolutely wonderful. And I'm also very fan of Carbetocin. And the people who are listening us should know about it, that intramuscularly, if you give Carbetocin, the effect lasts for 2 hours. So I think then it is much more effective if you give intramuscularly. So I think it was pleasure listening you. And let's have the comments from the other people. Thank you very much.
Thank you, ma'am. Thank you so much for your guidance.
First of all, my apologies. Actually, I sent a PPT, जो actual PPT है, one nation and one protocol PPT, and somehow by some mistake, huh?
You can display it, ma'am.
हाँ, by mistake, by mistake, I think I still have time. And एक आपके पास एक अभी है, आप उसको क्विकली प्लीज एक बार भेज दो तो हम लोगों को ना बहुत तसल्ली मिलेगी, मेरी मिस्टेक भी थोड़ी ठीक हो जाएगी.
No, but I think let's not repeat it.
Just quickly, without saying anything.
I think each one of us must know how the evolution has brought about and how Indian consultants have been part of these particular programs. And in fact, you will be surprised to know that quite a few of them have contributed in the final shaping of the WHO and FIGO guidelines. I think it was a pleasure listening to you again.
Thank you.
Please show the certificate, a small token of appreciation to our star speaker, and please accept Dr.
Congratulations to you, Dr. Pratik Tambe. This kind of certificates you don't require, but this is a part of our strategy. Our wish will be that people who staff working with you, all the people who are working with you, we will send that particular PPT. You should see to it that particular thing is transferred to each one of them. And once, sir, you also read it, you'll find it that you are 25% more clearer as far as your action is concerned. This is what I realized it that once we read that particular presentation, I felt I think a couple of things were very much clear to us, which were not clear for so many years. We have been practicing for the last 5 decades or so. So I think I will definitely like you to go through that particular thing. We have not added a single line in that. It is
Yes.
all pure FIGO WHO guidelines. Okay.
All right.
Anybody wants to make any comment?
ऐसे प्रतीक के बोलने के बाद कुछ लगता नहीं और आपके समझाने के बाद देर आई डोंट थिंक दिस इज
नहीं
एनीथिंग वी
नहीं
कैन डू
मेरे को समझाने
बट
वाली कोई बात
प्रिवेंशन
ही नहीं है,
हाँ
कोई बात ही नहीं है.
prevention because the prevention the slide the ppt we are talking about, it has actually prevention and early treatment and recognition including e-motives and all. It is complete ppt and what to do and when to do and especially the protocol for referral, because generally gynecologists we understood that in India the tragedy lies in delays, delay in action, delay in recognition and delay in management. So that golden hour management, because 2020 it is it was said that even in some part the patient is hemodynamically unstable and the shock index is more than 1. So these are very simple things. By taking the blood pressure and pulse and heart rate, we can definitely diagnose and work accordingly to diagnose that patient is already in hypovolemic shock, and the simple calibrated drapes to estimate blood and timely escalation. This emotive is this treatment bundle is something very good for treatment, and prevention part you have already discussed very nicely. And because I told you, asked you, because ma'am, Pratik was in a big program of East Zone US, that thing, and he was very busy. I think when talking to him, I missed the message, and that should not happen in the management of PPH, that we should not forget in even a single line.
No, his presentation had been people who are listening it for the first time. It was very informative. I think all of us must know it. What has gone into the final, making of these WHO and the FIGO guidelines. Pratik, it had been absolutely a pleasure.
Thank you, ma'am. Thank you very much.
Yes, thank you for coming and thank you for giving us time. Any,
I will send that particular PP to you.
All right. I'll have a look. Thank you so much. Thank you for sharing.
And Archana Sharma, Anita, Sneha, are you there to say
Yes,
good evening?
Yes.
I'm very much here. It's always a pleasure to listen to Dr. Pratik because his talks are always, evidence-based, very properly organized, and of course, very informative and giving a very precise message, especially what is the plan of action and how he has already expressed his views also regarding how it is not good for I would say a developed country like India now to have such a high toll of maternal mortality. So it was an impressive presentation. Definitely, in fact, we are in awe of this mission, I would say, madam. And I wish that every obstetrician gynecologist of India follow this so that, rather than treating the PPH and, preventing mortality, we have to identify at the earliest and try to prevent PPH. And if at all we land up in PPH, we should be well equipped, well skilled to manage this PPH. I think that's very
Yes,
nice.
very good. Sneha is very right. You are very right in saying that birth preparedness is we definitely need to know, and knowing the high risk factors and managing their deliveries at proper center and timely management is very important. So I think one question I want to ask Dr. Pratik, वैसे तो you are the infertility specialist and all. I hope there is no gynecologist who doesn't do cesareans and other normal deliveries, and your team actually must be taking care of everything. What do you think that role of NASG, and what is a basic about that? Have you ever used those cannulas, and any experience with them, or just no?
Fortunately, I have not had need to use the cannulas, And NASG, I have seen, especially in demonstration and skill drills, it's very essential for our paramedical staff and people from the periphery to be aware how they are to be utilized so that they can transfer the patient in a good condition. Ensuring that care is there in the first 2 hours immediately after the PPH occurs is actually more beneficial than all the other heroic surgeries that we do later on. That initial care that we render to the woman is utmost importance to save her life.
Very true. Actually, whenever we talk, we always talk with the stalwarts, and they whether they are at AIMS, anywhere, medical college, tertiary center, they very proudly say we don't use NSG because हमारे यहाँ तो patient आता है तो हम तो manage करते हैं, हम तो ये करते हैं, हम तो वो करते हैं, वही
लेकिन वो
problem है.
पेशेंट कहाँ पहुंचने तक जो उसके ऊपर बीतती है, दैट यू एंड आई नो.
सो सो यही चीज मैं आपसे रिक्वेस्ट कर रही हूँ कि आप अपने साथ पूरी टीम को इसको भी अपने उसमें कर लेते हुए कि हाउ टू रीच अनरीच्ड, और जैसे उनके वो ये जो चीज है कि वहां से पेशेंट प्रॉपरली किस तरह से हैंडल करके टर्शरी केयर सेंटर तक पहुंचाया जाए, उसके ऊपर मतलब ये भी हमारी कंफर्ट जोन से निकल के ये अपील भी एक जरूरी है,
We
क्योंकि
have to go out into the community. We have to spread the knowledge. We have to spread the word. And this has to be done periodically to reinforce the message. वो एक बार
Yes.
जाके भाषण दे दिया उससे कुछ नहीं होगा. That has to be inculcated in them.
Dr. Pratik, what we want in this particular movement is that this particular PPH, PPT should be read by a person, should be rehearsed by a person before making a presentation to 10 of your
Absolutely correct.
friends and 10 nurses. Because once you read this particular thing, you find I've remained a teacher for such a long time, and I found, that I was 30%, my knowledge was much more clearer after this presentation. So I think, that's the beauty of it, that this presentation is not to be heard by somebody. It should be read, rehearsed, and then presented. So that will
Absolutely.
make all the difference. That will make all the
Absolutely.
difference. And now we find that as far as this shock garment is concerned, people in Delhi, nursing homes, they have started keeping it, and they find it, though it's not the treatment, but it gives you 20 minutes time, to organize oneself.
Even very rightly said, madam. Basically, PPH was always very close to my heart, and I was doing all sort of. जैसे प्रतीक ने कहा भाषण वाले प्रोग्राम में बहुत कर रही थी, तो अभी आप इसको जोक ना समझे बिल्कुल. जब द मोमेंट आई मेट डॉक्टर शारदा जैन मैडम एंड that day 2nd November, it created history, and since that day only I decided that now I will not do anything else except the PPH awareness, and that this is my dedication, this is my commitment. And because really India really need छोटे छोटे जो डॉक्टर्स हैं ना, जो सारी कम्युनिटी में घूम रहे हैं, जिनकी अप्रोच बहुत ऊपर तक नहीं है, आगे नहीं है, वो 80% तो अपने ही प्रैक्टिस में एस्टेब्लिश है, वहीं सारे ब्लेंडर हो रहे हैं, एक अकेला अपना बैठे हुए हैं, उनको वो अपने हिसाब से मैनेज किए जा रहे हैं. ऑक्सीटोसिन कितना देना है, फ्लूइड कितना देना है, उस पर कितना प्रॉब्लम है, मतलब जैसे ग्रे कैनुला लगा दिया, 8 बॉटल भी चढ़ा दिया, तो उनको ये लग रहा है कि शॉक मैनेजमेंट करना है हम, और चाहे उससे डाइल्यूशनल कॉगुलोपैथी हो जाए तो भी उनको मतलब, क्योंकि जब तक वो पता ही नहीं है तो बुकिश नॉलेज से काम नहीं चलेगा. और ये जो अभी है, तो नेक्स्ट टाइम ऑल्सो डॉक्टर प्रतीक एक बार इस पर डिटेल में बात कर लेंगे. दिस पीपीटी मतलब मैंने से बोला भी, बड़े बड़े शहरों में ऐसी छोटे छोटे बातें होनी
No,
नहीं
sir.
चाहिए.
I think, we've had a 20 presentation by people, couple of them in Haryana and all, and Punjab have said that in the last 5 years, they have not had a single PPH death. It is so very heartening,
Yes.
They're following the protocols, and everybody said it is the birth preparedness and it is the active management of third stage which has prevented 80% of them. Now, whenever they have the particular problem, nowadays, they have started putting a small monitor, so they have things ready in front of them. The pulse and the blood pressure is ready with them, and they find, this protocol of PPH bundle has helped them a lot. People were in praise of the suction cannula, which is promoted in down south, and they were very happy. The people who started using it, they were very happy, and they said, this once you use it, you do not require a uterine balloon therapy. In fact, people who are using uterine balloon therapy, they find it is ultimate. But those people who are using this cannula, they also find it is equally good. So that's why she was asking you, what is your experience about using this particular
Yeah, personally, I don't have much experience, but I have met Dr. Parnikar almost 10, 12 years back. 2013 is when I first met Dr. Parnikar and I was introduced to his cannula. And at that time, we were going to write a book on instruments for postgraduate students. I remember Dr. Suchitra Pandit and I were going to be the co-authors. So at that point of time, I got in touch with him. I got to know about the different designs, how he had gradually evolved the cannula to the finished and refined product which we use today. So it's something which is amazing. You are actually witnessing history taking place and how things have undergone evolution. It was an amazing learning experience.
The other day I was asking Dr. Charmila and a couple of more people from down south, and they were very happy as far as suction cannula to be used, especially in high risk cases when they know that it is this patient probably may have it right after the delivery. They have started using it after the delivery of placenta. They're very happy. They were very happy. That's why they were asking that. Now, what is your opinion about the same?
And actually, they have made it something which is part of their guidelines for the Kerala Federation. They have incorporated that in their standard of care, the entire cannulas and the suction concept.
Okay. डॉक्टर प्रतीक, हम लोगों ने जैसे बीच में कई सारे प्रोग्राम्स किए, तो एक आगरा की टीम है, उन्होंने कहा हम जिस गवर्नमेंट मेडिकल कॉलेज में जो वाइट प्लास्टिक शीट एप्रन पहन के करते हैं, उसी को रैप करके खट 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 2 सेकंड में उसी से बना के हम बना लेते हैं, और उसमें उनका फ्री का कैलिब्रेटेड ड्रेप बन जाता है. उन्होंने स्केल से उस पर स्केलिंग कर देते हैं. तो और उन्होंने ईमॉक ग्रुप बना रखे हैं कि जब पेरिफेरी से पेशेंट चलता है तो उनके उस ग्रुप में आ जाता है वो कहाँ पे क्या कर रहे हैं, और वो अलर्ट रहते हैं. JN Medical College Aligarh में they said कि they have not seen any PPH death. That is very really a proud moment for last 3 years.
And they must be having
Similar
a
way,
good journey.
Aligarh people also said, the Aligarh Medical College people also said they've not had a PPH death in their place.
Amazing. And they must be
I
having
think
a
things
huge
are
journey.
improving, Doctor.
Yeah, absolutely. Now, things are improving. And as I said, we have already exceeded the Millennium SDG goal. Now, the next step is to see to it that we stand number 1 in terms of PPH deaths, the lowest anywhere in the world.
Let's see that.
उत्तर प्रदेश में अभी बहुत ज्यादा जरूरत है.
If we reach out to every gynecologist,
Now, this is a fantastic project that we've undertaken, and I wish you every success. And Archana ji is always a stalwart crusader. Whichever cause she takes up, वो हिला के रख देती है पूरे इंडिया को.
Doctor, her connections are very good. It is a Foxy training, A Foxy training is working very well.
Absolutely.
Ma'am, me and Pratik have worked so much in Foxy together, and he knows कि कैसे कैसे सही तरीके से कैसे काम करना है. He knows it very well. कोई इनके तरफ से कभी भी कोई ब्लेंडर मूवमेंट होता नहीं है. अभी वो जैसे PPT वाला जो इशू था ना, ये बिकॉज ऑफ मी मैंने ही वो थोड़ा हो गया. कोई बात नहीं सर, एक बार और फिर से हम जरा दोबारा से आपको PPH गाइडलाइन जरूर बुलवाएंगे. सो थैंक यू वेरी मच. आज संडे का दिन है, होली है सबके लिए. आगे से सब हैप्पी होली टू ऑल एंड गुड विशेस टू यू. Soon Pratik will become upper in ICOG, and
मैं इधर ही ठीक हूँ.
we will do.
I'm a grassroots worker. I'm fine here.
Thank you so much, sir. Thank you so much.
Thank you, madam. Thank you, madam, so much. Thank you, ma'am.
Thank you so much.